I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Hello, and welcome to the September 2016 edition of the PRS Journal Club. My name is Raj Sawh-Martinez, and I'm joined by my fellow resident ambassadors, Amanda Silva and Sammy Sinno. This month, we have the privilege of being joined by Dr. Liza Wu, an associate professor of plastic surgery at the University of Pennsylvania. Thank you so much for taking time out of your hectic schedule to join us, Dr. Wu.
Oh, absolutely.
For this discussion, we'll be focusing in on the study by Dr. Christian, Fisher, Dr. Basta, and Dr. Nahabedian, which aims to find out if single-stage prosthetic reconstruction is cost-effective via a cost-utility analysis comparing single-stage direct-to-implant reconstruction relative to two-stage traditional expander-implant reconstruction in post-mastectomy patients. The authors note that advancements in technology, improved mastectomy techniques, and greater clinical experiences have really now led to improved results in single-stage breast reconstruction with a lowered incidence of adverse events as were originally reported. Although prior studies have looked at the costs associated between these two reconstructive options, they note that their analysis goes beyond perioperative costs and really includes outcomes and quality of life analysis for their patients. The authors use Medicare reimbursements, estimated billing charges, professional fees, patient out-of-pocket costs, and hospital charges for inpatient stays in their analysis, and they compared national reimbursement and Medicare reimbursement in their cost analysis. Complication rate probabilities and the associated costs of these were also factored in through a detailed and algorithmic approach. They also determined a, quote, utility parameter, which was based on a survey of 15 senior plastic surgeons that ranked varying post-op health states related to specific complications. These utility scores were then converted to quality-adjusted life years, which we're all pretty familiar with. To determine the complication rates and probabilities for their analysis, the authors actually reviewed all the existing literature through the major online databases and found a total of 6 studies which met their criteria, which included a total of 791 single-stage direct-to-implant reconstruction patients and 1,142 two-stage expander-implant reconstructions. The authors calculated what's called an incremental cost-utility ratio. This is a ratio of the difference in expected cost of the reconstruction, one stage minus two stage, relative to the difference in expected quality-adjusted life years between the two types of reconstructions. Although admittedly this is a bit complicated, they explained that the single-stage procedure would be deemed cost-effective if this ratio was greater than 0 and less than the standard threshold of payment of $50,000 per quality-adjusted life year. In the author's review, they found a similar rate of complications for one- and two-stage reconstructions in the literature of 35 versus 34%. When using Medicare reimbursement rates, their analysis found a cost decrease of about $525 and a clinical benefit of 0.89 quality-adjusted life years, resulting in this incremental cost-utility ratio of $590. When national hospital charges were accounted for, the cost decrease was found to be $4,492, with an equal clinical benefit of adjusted quality-adjusted life years, resulting in a total ratio of $5,047. They did sensitivity analysis for multiple factors, and some of the highlights here include the fact that they found that the influence of acellular dermal matrices did not actually affect the overall cost savings, even when they counted this for its use in the single-stage reconstruction, but completely left it out as a potential use in two-stage reconstructions. They also found that when they varied the revision rates in this sensitivity analysis, they showed that making an unplanned revision rate of 100% for the direct single-stage implant reconstruction, while making the revision rate 0% for the two-stage reconstruction, they found that the single-stage reconstruction still remained cost-effective. Overall, this is a well-executed, sophisticated cost analysis that demonstrates the cost-effectiveness of single-stage implant-based reconstruction compared to the two-stage reconstruction. Like all cost analysis, the fundamental assumptions drive the conclusions, and the authors note in their discussion that these may be two separate patient populations. As sophisticated surgeons will know that those patients who use tobacco products, have had radiation, or have thin mastectomy flaps, among other patient populations, are often not candidates for single-stage reconstruction overall. Nonetheless, the study will surely add to the demand that exists, I think, out there for single-stage reconstructions. And Dr. Wu, we're really privileged to have you here with us, and I know our listeners are going to be, dying to hear what your perspectives and experiences are on this. Are you a fan of single-stage reconstructions. Do you think that there are similar complication rates between these two groups?
So, if you just look at the concept of direct-to-implant versus two-stage implant reconstruction, of course, direct-to-implant, if it works at low complication rates or comparable complication rates, is of benefit to everybody involved. It's beneficial to the patient, it's beneficial to the surgeon, it's beneficial to basically the health systems. I'm just glad somebody was able to put numbers to that and actually validate that argument. And they did it quite well. And I think you did an incredible job summarizing a very, very complicated analysis of the data. So I want to applaud you for that, and I want to applaud the authors for putting forth this paper. But I think, what happens with this type of cost-utility analysis is that there's a lot of assumptions that are put in place. And some of these assumptions regarding, health states may or may not be all that accurate. So if you look at some of their assumptions for their health states, they talk about, the different types of complication and the quote-unquote costs of these types of complications. And again, there's a lot of assumptions put forth, and the truth of the matter is complications can be very varied in patients, and not all hematomas are treated the same, not all seromas are treated the same, not all mastectomy flap necrosis is treated the same, and not all capsular contracture is treated the same. So again, with such a complicated analysis where they're making a lot of these assumptions, they're doing the best that they can, but it may not be all that accurate. So, that's something that you have to keep in mind when you read this type of article in which they're doing a cost-utility analysis. But otherwise, like I said, I think this is a great paper. I personally believe that direct-to-implant reconstruction is something that we should all strive for. Unfortunately, the one thing that I think so many people just gloss over, and I'm not sure why, is that direct-to-implant reconstruction is only possible when you have a mastectomy that leaves skin flaps that will support a full-size implant at the time of the mastectomy and reconstruction. Period.
Right.
We don't do direct-to-implant reconstructions at our institution because they would fail. Our rates of mastectomy flap necrosis would increase. So our complication rates would increase. So all of a sudden, for our population, for our patients at my specific institution, this analysis doesn't hold true for the one fact that, the one thing that we don't have control over is the mastectomy results, the thickness of our mastectomy skin flaps. And that mastectomy flap necrosis, the rate of mastectomy flap necrosis is so much higher. And that leads to higher complications for direct-to-implant. So again, although this is a beautiful paper with its analysis and et cetera, it doesn't take that into account.
Dr. Wu, I just have a question. When you're considering single-stage reconstruction for a patient, since this is a relatively newer thing that we're doing here at NYU as well, I can honestly say I really haven't been in the preoperative consult for a patient that had received one of these procedures. So what in particular, what are some of the highlights of what you would tell a patient in sort of preparing them for undergoing this surgery compared to sort of the classic two-stage?
For patients who request direct-to-implant reconstruction, I always consent them for possibly converting to a two-stage procedure depending on what their skin flaps look like at the conclusion of the mastectomy. So that's number one. That's what I caution them against. I don't do it in patients who smoke because, again, these patients have higher rates of mastectomy flap necrosis and would not have or are prone to more complications if we try to go direct to implant and would probably fail. I don't have, numbers to back that up because we do a very small amount of direct to implant reconstruction at our institution. I tell them that the size that they want to be may not be entirely in their control. So for two-stage implant reconstructions, generally I tell the patients they can choose whatever size they want to be within reason. With direct-to-implant, I limit them to probably no bigger than what they were preoperatively. So if a patient comes in and she's a B-cup breast and she wants to be a C or a D-cup breast, direct-to-implant reconstruction probably would not be successful in her. And again, it all has to do with the thickness and perfusion and viability of the mastectomy skin flaps after the mastectomy is completed. So when you put extra stress on those skin flaps with a large implant, they're not going to do well. I do counsel patients that they have to be okay with using some sort of dermal matrix when we do direct-to-implant, because that bothers some patients. But typically when you explain why you have to use it and what it is and there's no infectious complications, they're okay with it. But that's another thing that I do talk to them about. I don't necessarily find that there's increased rates of seroma. Again, I think the increased rates of, the earlier reports of increased rates of infection were related to mastectomy skin flap necrosis and wound healing problems. So those are kind of my thoughts with regards to the whole direct-to-implant versus two-stage implant reconstruction. It's something I think everybody should strive for, really. But it has to be within an environment and a setting in which, all the factors have to be in play for you to have a successful outcome.
I see. Yes. Those are great points, Dr. Wu. And I was just going to ask if, have you found over time, are patients starting to, especially with skin sparing or nipple sparing mastectomies, are patients coming in asking for these more often than not than in the past, would you say? And then the authors make a point too at the end that, obviously a randomized controlled trial would certainly help us get more data and answer this. But in my mind, it seems almost impossible for all the different factors you just listed to actually do that. I mean, who do you then randomize? The patients who don't smoke, who have thick flaps, et cetera. And then the expectations are different because the patient who would qualify has to understand that they will not get a larger reconstruction. So that also seems to be a limit there to truly ever randomize between these two groups to know if it's truly an equal surgery. Because to me, this seems like two radically different groups that would receive these different surgeries.
I don't know if it's two. I think anybody, I think, if you are a woman who presents who can have a skin-sparing mastectomy, you should be able to have a direct-to-implant reconstruction. Again, that's if all things are equal. Unfortunately, not all things are equal because, people's surgical styles, the thickness of your skin flaps, and that's all kind of predicated on who your breast surgeon is and the quality of your skin flaps that are left from the mastectomy surgeon. So how do you kind of level the playing field? Multi-institutional, that's the only thing I can really think of, a multi-institutional randomized prospective study where you kind of try to capture kind of all breast surgeons and all techniques, and it would have to be very large scale. Or what you could do is decrease the or the exact opposite, decrease the variability. So take the unknown factor out of it, so the thickness of your skin flap. Start doing our own mastectomies. Leave skin flaps that are uniform and the same and what we want. But you see what I'm saying? So those are basically the two ways that I can think of to kind of figure out what is the best. But again, intuitively, direct-to-implant is the best. And you can control for a lot of things, using the alloderm and creating your pocket and et cetera, et cetera. So yeah, but again, it's not applicable everywhere.
I would just kind of 2 points. First off, a randomized controlled trial. Do you think though that patients kind of come in, at least from what I've seen, patients come in and say, I want a direct implant. They're coming to you because they want that. They don't want to deal with an expander and going through the cells. Like they're actually okay with things not looking 100% perfect. It's just the comfort of just being able to have a surgery and potentially just one surgery if they're okay with not getting a tiny little revision. So I don't know if patients would really want to be put into a randomized controlled trial for breast recon.
Yeah, I definitely think it would be a problem trying to get people enrolled into a study like that. really.
Yeah.
I mean, really. And that's why, again, this is a study that, all 6 of the studies that they included in their analysis were all retrospective.
Yeah.
Right.
Yeah. So,
and then my other
again,
point, actually, Dr. Oh, sorry, go ahead.
No, please, go ahead.
So my other point was actually what you brought up, doing your own mastectomies. Could you speak a little more about that? Because I've heard through the grapevine that you might be doing a fellowship soon, and maybe you could give a little perspective on that and what your thought process is behind that.
Right. So again, like I have to say, I currently don't do a lot of direct-to-implant because we've tried and it doesn't end well here. So I have decided to take matters into basically my own hands so that I have control over the outcome of my patients. Total control over the outcome of my patients. So yes, I am doing a surgical oncology breast fellowship so that I will be able to perform the mastectomies as well as the reconstruction in my own patients. And again, that is so I can have the most control over the outcomes, cosmetic outcomes of my patients in the end. And yes, it's so that I can offer patients direct-to-implant reconstructions, so that I can offer them oncoplastic procedures. These are the patients that, unfortunately, as plastic surgeons, we don't capture right out of the gates, so we can't really offer them kind of the best of reconstruction or outcomes in my mind, because again, we're relying on so much of the outcomes on somebody else's procedure or part of the procedure. So yeah, I mean, patients are very savvy these days. They do their reading and they come in and they request, direct-to-implant reconstruction. And I simply tell them that, this is something I would love to offer you. You have to be the perfect candidate for it. And not only do you have to be the perfect candidate for it, you have to have beautiful mastectomy skin flaps when they're done with a mastectomy, period. So I do offer direct-to-implant reconstruction, but I also tell them that I have to reserve the right to put in a tissue expander and convert to a 2-stage, and they have to just trust me. At the end of the surgery, I have to, evaluate their skin flaps and determine whether or not they're a good candidate for direct-to-implant. So how much do you guys do?
We actually do a decent amount. I feel like we're doing less and less expanders, although it's I think it also depends on, patients whether they're going to get radiation or not. So any patient that's going to get radiation, we usually just say, get your mastectomy and we'll do an autologous free flap later. But patients who are good candidates, we've been doing a lot of direct implant, fewer and fewer tissue expanders.
So what changed? What caused you guys to move more to direct to implant? Because I know your breast surgeons are all the same.
Yeah, I think patients requesting it, in all honesty. Patients coming in and saying, this is what I want.
I'd say that. I think that's, by the way, amazing what you're doing, Dr. Wu, and that's really, I think, going to be something that a lot of other reconstructive breast surgeons are going to probably start doing once they hear your rationale. I would say, echo Amanda's point, that most patients are seemingly asking for it. And I do say that there are some breast surgeons now that are paying attention to these things. I mean, they see us trying to do spy studies or, looking at, and we're publishing a lot of our data on implant-based reconstruction. And in the August journal, we have an article from our institution on the breast in a day procedure. So I think it's a combination of really working a little bit more closely and communicating with our breast surgeons, even some of the senior breast surgeons who are willing to try to make it work for the patient and give them the best possible outcomes, because ultimately it's their patient too, and they want their patient to be happy in the long run. If we're doing more of these procedures, they're going to want happy patients.
Yeah, absolutely. Absolutely. And again, it's one of those things where a lot of it is awareness, kind of teaching, showing, and discussing and working with your breast surgeon and say, these are what our goals are for our patients. Because a lot of times they don't know unless you tell them, this is what patients want. This is what we need from you to be able to give them what they want, within reason. Obviously, they still have a goal. They have to remove all the breast tissue. So, we'll see. We'll see how this kind of plays out. But I do believe that this is going to be what the future of implant-based reconstruction is. And to take it one step further is kind of all the pre-pictorial implant reconstructions that you're seeing now. This is pushing the envelope even further.
Right.
So it's really interesting to see where these things are going to lead us in the next, few years.
Yeah, and congratulations, Doctor. We really, sort of going that extra mile for your patients in trying to provide them the optimal care and meet their needs. I think, just to answer your question from our perspective, it's certainly been, like Sammy mentioned as well, sort of patient, demand or patient requests that are sort of pushing that envelope. But we face the same issues with, one, you'll have issues when the mastectomy flaps really don't fit the right patient to have that single stage, and occasionally you'll kind of push the envelope and get bitten by that. And so that's not great either, because then you're still not doing a second procedure and having issues and potentially losing the devices, which is not great. But there's that variability. And even within surgeons, sometimes, from case to case, sometimes they're thicker or more thin and compromised flaps. So I think that adds an added challenge. And we're sort of, I think it's a great idea, Dr. Wu, because, it's sort of the reverse. In Europe, some breast surgeons are putting in implants themselves, the oncologic surgeons. And I think in seeing that complexity, they're more keen to take just breast tissue instead of that subdermal fat that was what leads to all this flap necrosis. And I think it's sort of a difference in that mindset of, well, what are we really trying to accomplish here? And I think the ultimate studies are going to be the ones that show no recurrence rates with thicker or appropriate flaps, instead, saying thicker with appropriate flaps. I think that's going to potentially change that pendulum, so we can actually offer this to patients routinely.
Yes, definitely. I want to tell you guys about at the upcoming ASPS meeting in Los Angeles. Are you guys planning on going?
Yes. Oh yeah.
Oh yeah. Mhm.
Yeah. So there is a panel at the ASPS it's going to be an international panel, and it's going to be basically the management of breast cancer and mastectomy and reconstruction. So we basically have a panel of international surgeons, and they talk about their approach to the management of breast cancer with regards to mastectomy and reconstruction. And in England, we have somebody from England, we have somebody from Germany, we have somebody from Spain, we obviously have people from the U.S. and then from Canada. And we actually have an OBGYN who does the mastectomy and reconstruction, both autologous and implant-based. So it should be a really eye-opening kind of discussion kind of on what we have basically started talking about during this discussion on this paper.
Yeah, that sounds great.
Great. Thanks for letting us know. It sounds really exciting, yeah. Well, with that, I think we'll wrap up. Oh.
Great.
Yeah, thank you so much, Dr. Wu, for your time, and we'll see you guys next month. Take care.
Great. Thank you so much.
Thank you.